Thank you. It is a great pleasure to be here and share with you my thoughts on whether we should be treating patients with large baseline core volumes or low aspect scores. These are my disclosures. And I think we should start by sort of acknowledging that there are two types of patient populations with large vessel occlusion: the fast progressors and the slow progressors. And that's important because I personally approach patients differently and use imaging differently depending on whether patients are in the early time window, when we're dealing with a lot of fast progressors, versus the later time window when we mainly focus on slow progressors. So as everybody knows, when the vessel occludes in the brain, we have progressive growth of the ischemic core, but that can occur at fast speed. That characterizes the fast progressors, people who have poor collaterals, and slow speed, the lucky ones, the ones who have good collaterals and their stroke grows slowly. And these are the kind of prime targets for dawn and diffuse 3 for patients that we treat beyond 6 hours. And the reason why I want to start by making this distinction is that in the early time window, which arbitrarily we choose 0 to 6 hours, we're dealing with a mixture of patients, about 50% of which are fast progressors. And we have to be mindful of those patients, because in these patients, any kind of time leads to very serious penalties in terms of good outcomes. Different with slow progressors, in that time window, beyond 6 hours, we deal mainly with slow progressors, and the penalty that we pay by spending time is actually much steeper. So this is an example of a fast progressor patient with an M1 occlusion at 4 hours from symptoms onset. MCA occlusion is already completed, as opposed to a slow progressor, same vessel occlusion at 11 hours. Stroke is small and the territory at risk is still significant. So back to the issue of a large core and whether we should be treating patients with large core. As I said, I kind of approach this question different depending on the time window we're in. But first of all, let's try to understand the definition of what is a large core. How do we define that? In general, we measure it with the aspect score. That's the title of this talk. Should we treat patients with a low aspect score? We use aspects as 0.4 as sort of the designation for a large core. And we can do the aspect score on MRI as well. But recently, and especially when it comes to MRI, but also now when it comes to CT, we use volumetric analysis. We all know the software packages that measure infarct on MRI, but there are now software packages that measure infarct on CT. Brainomics is a automated aspects segmentation and measurement. There are companies that actually measure the infarct based on hypodensity on CT. So not only MRI can give us volumetric analysis, CT as well. And the question with large core is what is a large core? Is it a 70 cc's? Is it 100 milliliter? And should we age adjust when we talk about a large core? Is a large core the same for somebody who's 90 years old versus somebody who's 50 years old? I probably not. Probably for, even though in absolute terms the core is large, that doesn't mean that the indication for treatment necessarily should be the same for a given large core for a young versus an old patient. So these are all things that we need to still sort out. Now, one thing to remember is that with CT perfusion, and I have shown CT and MRI, CT perfusion is a technique, an imaging technique through which we derive the core based on blood flow studies. And for a long time, we did believe that these measurements are accurate. However, as we open vessels faster, we realize that the thresholds that define core are a moving target. That the earlier we reperfuse the patients, the more stringent we have to be, or more liberal we have to be, on the other hand, with the thresholds that define core. Also, we need to consider that these thresholds are different for gray or white matter. With other words, CT perfusion is challenging in terms of defining core. And that's something that we are realizing more and more. This is data from Hermes, again, confirming what has been shown before, that these thresholds are time dependent. So please keep in mind, this is imprecise science, trying to define the core based on CT perfusion. And in general, it is a very difficult and challenging undertaking. There's now papers showing that in clinical practice, there are actually lots of patients who do have a large core by all the definitions of core, and actually after reperfusion, it turns out that that the tissue is viable. Again, challenging even by the more recent definitions of core, challenging in general the concept of defining core based on perfusion imaging. This is data from Barcelona showing that about 20% of patients that are reperfused after having a CT perfusion show what we call a ghost core. With other words, a core that is present on CT perfusion, but on follow-up imaging, the tissue is viable, and the size of the ghost core, the percentage of ghost core is proportional to the time with the earlier the percentage of ghost core is larger in the earlier time window. Again, confirming what I have shown in previous slides, that this is a moving target, and especially in the early time window, the thresholds that define core are not clear. Now, when it comes to the broader question, not exactly how precise we measure the core, but are we dealing with a large core, yes or no? It turns out that according to more recent data, an aspect score of 7 or less is about equivalent with a CT perfusion infarct volume of 70 cc's or less if we use MRI as the gold standard. But it actually turns out that even when we use MRI as gold standard, some of these MRI lesions reverse. This is a meta-analysis published recently of many studies that looked at DW MRI at baseline and volume of DWI or flare after reperfusion. The conclusion is that reversal of the DWI lesion is seen up in a quarter of patients with acute stroke. And just like in the CT perfusion case, this reversal is more frequent in the very early time window. So bottom line, I want to make the point that it is very challenging, especially in the early time window, to define the core by any imaging study, okay? And then on top of that, we also have to deal with the eloquence issue. This is a very recent paper showing that when you take into account eloquent areas in the brain versus non-eloquent or less eloquent, the volume of and mismatch counts more in these eloquent areas in terms of reperfusion and predictor of a good outcome than in non-eloquent areas of the brain. Now, I think we remain, what constitutes eloquent versus non-eloquent is still work in progress, but that is another dimension of this story of reperfusing large cores. Which areas of the brain are we reperfusing? And that is an area of active research. Now, how frequent are patients with large core in the early time window? It turns out that these patients are not frequent. If we define large core as an aspect 0.5, so it's a more generous definition, not aspect 0.4, it turns out, based on this case series from University of Buffalo, and that in the 0 to 6 hour time window, there's about 16% of patients who have a large infarct. This is data from the Catalan Stroke Registry. It's a population-based registry. All patients with stroke are included in this registry. And you can see here in patients with NIH stroke score greater than 6, which is sort of a surrogate for large vessel occlusion. The proportion of patients with large infarcts, aspect 0.4, is just 2%. This is data from clot-bust, TCD-based intravenous TPA study conducted a while ago, showing that in the 0 to 3 hour time window when this study was conducted, patients with aspect 0.5 are exceedingly rare, just 4% of all patients. The earlier we are in time, that makes perfect sense, the less likely it is to encounter somebody with a large core, because at that time, in the first few hours after stroke onset, collaterals still function in most patients. This is data from our own research group at UPMC from 2 years ago, showing that in the 0, but this is by time epochs, in the 0 to 6 hour time window, patients with large cores, again, rare, 16%, in the 6 to 24 hours, 21%, but still overall low. And of course, if we use 70 or greater than 70 mLs, this percentage is higher. But overall, the data that we have right now is that these really large cores, and especially greater than 100 mLs in the early time window, are a rare occurrence. So number one, it is rare. Number two, is there harm from treating these patients in the when we treat patients with large core in the early time window? And I want to emphasize here in the early time window, because that's where we have most of the data that we're basing our arguments on. So this is data from Hermes. About half of the patients in the Hermes meta-analysis actually underwent a CT perfusion. And in these patients, by the way, you can see that most of these patients had mismatch, which basically means absence of a large core. So the vast majority of these patients in Hermes did have a absence of a large core, so moderate to small cores. If you look at patients with ischemic core volume greater than 70 mLs, not many patients, just 50, but the trends are very clear. Strong signals in favor of benefit of reperfusing these patients. And then a handful of these patients in the Hermes meta-analysis, 24 patients had core volumes of 100 mLs. And again, even in this group of patients, the trends are strongly in favor of reperfusion. That's very difficult to draw any conclusion just based on 24 patients, but certainly no signals of harm. And if you look at the baseline imaging study from Hermes, which I think is probably the most important paper that came out of the entire Hermes meta-analysis, we find now these are now 1,800 patients, a lot of patients. And we find that when we look at size of the core by whether it's defined by MCA involvement greater than a third of the MCA territory or aspect 0.4, once you have these large numbers, you can actually tease out statistically significant relationships of benefit for reperfusion in patients with large infarct. So I think all these myths that all these statements and concepts that we were used to before, that reperfusing large core is harmful, may just turn out to be a myth, just like many other concepts that sometimes we take for granted, and sometimes it takes revolutionary studies or experiments to contradict these findings, such as this study that had made a lot of splash in the news, published in Nature about 2 years ago or 3 years ago, showing that in pigs whose heads were severed and were left for several hours before being reperfused with a special serum, that even after 3 hours of their heads being severed, there was signs of viable neurons in the brain, not necessarily functional neurons, but there were signs of viable neurons. So kind of that brought down one of these myths that the brain does not survive after a few minutes of lack of flow. So I think that to me is a sign of not being dogmatic and having an open mind. And when it comes to reperfusing large core, that's exactly what I think we should keep in mind, and consider other possibilities of benefits of reperfusion in these patients with large cores, perhaps even a promotion of recovery or other neuroprotectant effects that we may not be understanding at this point. Yes, this is again data from the Hermes meta-analysis. Yes, if you reperfuse these large core patients, there's a higher incidence of symptomatic intracerebral hemorrhage, as you can see here. More symptomatic hemorrhages, although not a statistically significant, the higher incidence of patients with parenchymal hematoma, but there are certainly signals of worsening hemorrhagic complications, but the overall treatment effect is in the direction of benefit with these patients. There's more evidence in support of this concept. This is data from a large Swiss registry showing that, number one, as I mentioned before, these patients are rare, aspect 0.5 in this registry. And then when these patients are reperfused, this was a single-arm registry in patients who underwent thrombectomy. Patients who reperfused had much better outcomes than patients who did not reperfuse, still with a 32% rate of MRS02 in these patients with aspect 0.5, which certainly suggests that this is better than the natural history. This is a meta-analysis of trials looking at low aspect scores, in this case, aspect 0 to 6. And again, the signals are very clear in favor of benefit. 30% good outcomes in the treated versus 32%, I'm sorry, 3.2% in the non-treated group. And this is based on a large data set of over 1,000 patients. And this is a German registry that looked at predictors of good outcomes in patients with large aspect scores, in this case 0 to 5, and those were NIH less than 12, young age, and successful reperfusion. So it seems that successful reperfusion, even in these patients with large infarcts, is beneficial. Whether it's as beneficial as in patients with moderate or small infarcts versus less beneficial or more beneficial, that's something that future trials will have to clarify. So the other question is, should we even care about the size of the core in the early time window? Are we spending too much time trying to answer this question at the detriment of patients who have small or moderate cores who we know benefit from this intervention? And I think we have some very clear signals that probably we shouldn't care about large cores in the early time window, and that comes from a randomized trial, the AngioCat trial, that was recently published in JAMA Neurology. This is a trial where patients were either admitted directly to the angiography suite, or they went to the conventional path, which is direct to CT. I want to point out that this is already a revolutionary concept, going directly to CT, highly efficient. This center achieves door-to-puncture times of 42 minutes, which most of the centers, at least in the United States, can only dream of. But even when you're so efficient, going directly to angiography and treating everybody. So in this study, patients who went to angiography, everybody was treated regardless of the size of the core. The only thing that excluded the patients from treatment is absence of large vessel occlusion and presence of hemorrhage. In the direct to CT, in the CT guided or selected patient group, patients were actually excluded based on a large core, aspects 0-4. And at the end, in the primary analysis, all patients with a large vessel occlusion were included. So everybody in the direct to angio and patients who were treated in the CT selected arm, but also the patients who weren't treated in the CT selected arm, because that allows for a fair comparison between these two arms. And you can see already that in terms of the door to reperfusion time, there's almost a 30 minutes gain whether you go in the direct to angiography suite arm. And that results and translates into better outcomes among patients who go directly to angio, almost twice as higher rate of better outcomes. Now, this is a small study with a small number of patients, and we need to confirm these findings, but these are the preliminary findings suggesting that there is benefit by going directly to angiography and not caring about how large the core is in these early presenting patients. And again, this is a trial where everybody went regardless of the size of their infarct. And despite that, you can see here that the safety data looks pretty good in favor of going directly to angiography. No signs of higher rate of hemorrhages, no signs of procedural complications when patients go directly to angiography. On the contrary, the signals are all favorable to this approach. Now, granted, most of the data that I've shown does not come from randomized trials that have specifically looked at patients with large cores. I think that despite the signals that we're seeing, we need definitive evidence that treating patients with large core is not detrimental. But right now, the data that we have suggests that the signals are in favor of treatment. However, we need to confirm that, and there are several ongoing randomized trials. One of them is the LASTE arm of In Extremis. This trial is run out of France and includes patients with NIH stroke scale score greater than 5 and an aspect score from 0 to 5 that can be obtained by CT or MRI. And the time window, and that's very important, is 0 to 6.5 hours. And that is because and I'm part of the ones who designed this trial, we believe that the patient populations in the 0 to 6 hours in the early time window versus late time window are different patient population, and they may respond differently to thrombectomy. That's why trials are best conducted separately in these patient populations. There is another important trial. I'm sorry, there's another important question about late window large core. So again, late window large core, we haven't really gathered the kind of evidence that we have for the early window. How long can we go, and should we age adjust, as I mentioned before? We don't have answers, but there are some randomized trials that hopefully will give us some answer to these questions. Tension is running out of Germany. It goes up to 12 hours, and it has a criteria for size of the core aspects of 3 to 5 by DWI or CT. So that's number one. Number two is the Tesla trial in the US with a total sample size of 400 patients. The window there is actually 24 hours, and the aspects cutoff is 2 to 5. So these are exciting trials, randomized, they're ongoing, they're enrolling patients, and we will learn a lot more from these trials in the future. So in conclusion, I would say that in the early time window, we should not care about the core size because we can't afford it. We spend too much time trying to understand what the core size is at the expense of the vast majority of patients who have a small or moderate core size and who we know for sure benefit from thrombectomy. So we are hurting the overall patient population by trying to be precise about the core size, when in actuality, it looks like pretty much all patients benefit from thrombectomy. So therefore, the size of the core should not guide treatment. Speed is of the essence in the early time window. In the late time window, we certainly probably can afford a bit more time, but it is not clear that beyond the small to moderate core sizes, whether that large core patients benefit from thrombectomy. This is work in progress, hopefully clarified by some of the ongoing trials. And with this, I will end and will be happy to take any questions if there are any. Thank you very much.